All right, thank you so much to our three panelists, including my father, who's on the virtual link here. Doing a quick time check and knowing that our meal awaits us after this panel concludes, what I might do, if it's okay with David and Bridget, is move into the Q&A with the audience, if that makes sense, so that folks can have a chance to interact with our three pioneers. And since I'm getting the okay from Bridget, if folks would like to go ahead and move to the microphones, that'd be great. And while that's happening, I'll just take the liberty of asking one question to get us started off. There's been a lot of talk already this morning about funding. And one of the things that always impresses me when I hear this story of zero suicides is that the work started, although as part of a grant application process, the Henry Ford team was a finalist for that grant application process, but actually did not receive any grant money to do the work. So my question for the panelists to get us started is, how in the world do you do this if you don't have money to do it? Another way to ask the question might be, is zero suicides good for business?
That's a really good question, Justin. I'll talk about one part of it. David may want to reflect on this a little bit as well. First of all, there is a little bit more money than there seems to be, largely because of the gentleman sitting directly in front of me here, Richard McKeon, who has baked this into SAMHSA's suicide prevention grants, starting with the youth suicide prevention Garrett Lee Smith program. It doesn't mean that that's the sole thing you can do in working with youth, but it's expected to be one of the components of a response to that application. And then for reasons that maybe reflect a little synergy in the field, in 2 years ago with the 21st Century Cures Act, a small but important part of that legislation was that the United States established for the first time in its history an adult suicide prevention program and funded it, or authorized funding it, $10 million per year. But nonetheless, this is a starting point. And so, as Richard said in his opening remarks, the focus of that grant program is on implementing zero suicide, and the second round of awards have just been made to a number of states and tribes and health systems. So there is some funding. The second comment is that this is largely a matter of redesigning care that now exists, and the required activities are difficult to get to, primarily because we haven't done them before. It's not because it's that complicated, but it's been out of scope. No professionals have been trained in this, no medical professionals. Most behavioral health professionals haven't been trained. And so we primarily have the problem of inertia, but the activities themselves, doing a safety plan in an emergency department, would be considered within scope if it was a different medical problem that we had people there for, because it's going to take 45 minutes or so by a trained person to do this well. But these activities are yet, largely because of the lack of support throughout healthcare in general, people are having to figure out, setting by setting, how to get reimbursement for this, how to build the screening into the ordinary screening and assessment activities, how to do the safety plan. Is that billed as an intervention? Well, it is an intervention. How do you bill that? And most difficultly, how do you bill for the follow-up contacts that are so critical? So it takes a little bit of money. It takes more commitment. Commitment is scarcer than money, and money is an evolving opportunity.
Absolutely, Mike. So I was with a large health plan contract when I first started leading a zero effort. And there was some initial concern from the executive leadership of that organization that if we engaged in more screening and assessment, we would identify more individuals at risk, which would impact our medical loss ratio and lead to a reduction of profitability or even losses. But we had a hypothesis that, in fact, it's the opposite. That when healthcare professionals are afraid, don't feel skilled and trained, that they unnecessarily push people toward a process that disproportionately results in psychiatric inpatient hospitalization. Now it was a guess, but we did utilize a zero suicide approach for a several-year time frame, and we saw for those most in need, those on assertive community treatment, for example, that there was a significant reduction in hospitalization over the course of that time period. Now that, Justin, you're talking about an individual provider, not a whole system, but it may be that better care actually yields savings at the systems level.
I wonder if perfect timing. We must be related.
Well, just a word. I keep hoping that the money boat is going to come by. Maybe the hurricane will blow a pirate ship off of the floor of the ocean and bring it to Charleston here so that we can fund this work. But I don't think it's going to happen. And I don't think that we can expect the government, either through more funding or to fix this problem. I think we're going to have to fix it ourselves. And we're just going to have to find the dividend in the work that we're doing currently. And by that I mean we've got to stop doing things that don't work, just as Mike was saying a moment ago, and take that savings and invest it in things that we know do work. I'll be somewhat heretical here and say that at Henry Ford, we began to do less screening for suicide, not more screening. We wasted a lot of time trying to find a, quote, risk number, end quote, for each patient. What does that number even mean? We're not good at it to begin with. And let's say we did come up with a number now. Is that number today in the office going to be relevant 2 hours from now when the person is home and discovers that her husband is leaving her? So I think screening has a place, but we were spending way too much time worrying about screening and the precise number and then trying to triage according to some precise number. And instead, cut back on that and devoted the resources around safety planning and getting really much better at talking about means restriction and developing the appropriate safety plan. So I think we all know there's a lot of waste in the system still, and if we can find ways to get rid of that waste and take the dividend and apply it to suicide prevention, we're going to make a big difference.
Thanks to all three of you for those comments. Question from the audience? Nadine? Just a reminder to introduce yourself before asking a question.
Nadine Kaslow, Emory School of Medicine. First of all, I want to thank all of you for your really impressive and important work. I have a comment and then two questions. My comment is, our title is Preventing Suicide Among People with Serious Mental Illness. And I've been impressed so far that most of our conversation has been about suicide and its prevention. And I really hope that as these 2 days go on, we can make a more concerted effort to talk about this specifically as it relates to people with serious and persistent mental illness. So I hope we can all be mindful of that. I have a broad question and a more minor question. I'll start with the smaller question. Somebody mentioned the data about how many people die in hospitals each year. And that's resulted in JACO having all these ligature-free rules in hospitals. My concern looking at lots of hospital policies right now about this is it actually is quite dehumanizing for individuals who have that high risk number, that they wear a different colored gown, that their clothing is taken away from them, things to even write is taken away from them, and I am concerned that because of that high number, rather than doing prevention, we're doing humiliation and stigmatization. So that's one of my questions. My second question is, as you know, there are lots of critics of this zero suicide effort. People concerned that with the numbers going up, this is a setup for failure. And can you all talk about your thoughts about that and how to frame this in a way so that the critics kind of appreciate more what this is about and so that this movement and important effort can be successful?
Thanks, Nadine. Just on the Joint Commission thing, I have conflicting reactions to this. That this new paper that they're coming out also involves a careful look at the means of death in that actually relatively small number of people who die in hospitals, and 70% is ligature. And so I end up concluding that we can't not eliminate that. Morally, we can't not eliminate it. The second question, though, is how we go about doing that. And I hate these, super sterile environments. And I also hate that we haven't substituted enough of other things that would be effective, that would be supportive and relationship-centered. So anyway, enough on that one. And but the final comment is that if it's 100 deaths in hospitals, that's 44,000 something that are not in hospitals, including 3 times as many deaths within 72 hours after psych discharge as in the hospital. So I hope, and I don't know, but I hope that the Joint Commission and others begin to move away from that inpatient focus to what happens to people after, and then and eventually the larger health system. The resistance question is an interesting one, and I have multiple reactions to it. And I'm getting pretty old. I don't have that much time, which leads me to say, I don't have time for that. I'm only interested in who wants to do something, and what do you want to do now? What are your concerns about doing something? There's another part of this that is I think a perfectly, I don't know what the right word is, a real fear that, to me, is a subset of the general fear we have about suicide. We're not trained to do something about it. We're afraid of it. We distance ourselves from patients because of that. That's a bad thing. And because we're afraid of it, we're afraid that if we start focusing on it, there's going to be more pressure on me, and then there's going to be more blame if something bad happens. So that's there's a lot of complicated reactions in all that, but it suggests to me 2 things that are fundamental and foundational in starting to do this work. And one of those goes back to the stuff that Ed described about creating a just culture that seeks perfection but doesn't blame. That's hard leadership work. To do that, but it is foundational. And related to that, a second thing that will help enormously in this context is if we include people with lived experience in the planning, design, and oversight and carrying out of the work. I mean, I think we all kind of felt that we were changing and learning something as we listened to Taryn. And she's not the only person who's a genius about this. A lot of people who have been through this experience have that to contribute. And so my 2, I hope, constructive thoughts would be that attention to culture, to putting in place means of support if something does happen, and then of including people with lived experience in the process.
Just 2 quick comments, Nadine. First, I'm the CEO of a company called Recovery Innovations, or RI International, and we have about 1,100 staff who support crisis programs and wellness programs across the country in 50 sites. Those locations look different as a result of people with lived experience being substantial portions of the staff, and it goes far beyond what you're talking about. They're called guests while they're there. It's more like a retreat than it is an institution, more like a home. But just to your second question, just for a moment, any of you Breaking Bad fans? If you are, the last 2 episodes, the titles, the next to last episode was called Half Measures, and the last episode was called Full Measures. And the Golden Gate Bridge for 70 years did things that saved lives, lots of lives. but it was also a very unsafe place. And the complaints or the criticisms of doing something that would be a full measure would be it would affect the aesthetics. It would cost millions and millions of dollars to do. And besides, even if you saved everybody on the Golden Gate Bridge, you wouldn't save people on some other bridge somewhere else, or you wouldn't save people. You know what? They finally decided after 70 years, and it took a film that showed deaths, and it showed Kevin Hines and the tragedy of what happened to him in those final moments, for them to finally change and say enough with the half measures. They didn't convince everybody, but they decided in their backyard they were going to take full ownership and do everything they could do. And that's what we're really talking about for the healthcare for which we're responsible.
I think Ed has a quick comment.
Yes, I do. Thanks, Justin. And I agree with everything that Mike and David just said. I would add that we need skeptics. And so it's okay to be skeptical about zero suicide, at least from a scientific perspective. And it's okay to insist on a need for evidence to support what we're trying to do. We have to spend our money wisely, and as I said earlier, we can't do things that we know don't work. So that's perfectly okay, and we should encourage healthy skepticism. But as Mike said, if we don't have to deal, and we don't have the time to deal with cynicism. So I think as a leader, we have to make a distinction between whether what we're hearing is healthy skepticism versus cynicism. And then we have to make sure that we address the fear issue. I say again that we can't beat up people who strike out once in a while when we're asking them to swing for a home run every time they come up to play. So we have to work on this just culture. We have to build a safe environment where people are encouraged to innovate and be bold and audacious, but also at the same time to learn from mistakes. So that's my contribution here.
Bridget, I would be remiss if I didn't give Richard a chance to ask a question. Is that okay? Thank you. Please, Richard.
Thanks. So certainly a central part of the Zero Suicide Initiative has grown out of the recognition and the accumulating evidence that it's insufficient to prevent suicide among those with mental health concerns to focus only on the underlying mental health condition, and that you also need to focus on suicide specifically. And actually, those two things are a pillar actually of the VA's approach: suicide-specific care, but also good treatment of the underlying condition. But it's clear that behavioral health treatment within the healthcare system is going to take place under a number of rubrics in addition to zero suicide that may have implications for preventing suicide among those with serious mental illness. So my question is, if we look at areas such as the efforts to accelerate the identification of those with psychotic disorders, intervening in first episode psychosis or prodromal systems, or if we look at the broader issue of primary care efforts to treat depression, then the question would be, is there a way for us to, and should we be looking for ways to insert suicide prevention into those initiatives that are going to continue with or without suicide prevention? You know, is there a way that standard care for depression and primary care could be made more suicide mindful, or early intervention for psychosis? So if you could respond to that.
Richard, this is sorry, Mike, go ahead.
No, you go ahead, Ed.
Well, I'm just going to say, I think one way to embed such care across healthcare is, again, to focus on the safety plan. I don't think safety planning should be limited to people who are patients in the mental health care system. I would argue that every patient needs a safety plan. Every patient. Aren't those with cancer at risk for suicide? So I would start there. If you wanted to do one thing today that would make a difference about suicide care, I'd get very serious about safety planning for every patient in our healthcare system.
Thanks, Ed. So this is, in a sense, it's a complementary thought. Just a comment about primary care, and then a comment about specialty mental health care. So the primary care comment comes from the first time we did a zero suicide training boot camp. We call them Zero Suicide Academies, and had a whole bunch of people there, including a team from Kaiser. And one guy on the team, I don't know how he got there, was an internist, and he wasn't in a big group practice. He was like a small practice, and I'm thinking to myself, oh my God, what is this guy thinking about? All this conversation in the deep end of the pool. And so I asked him that at the end of the day. I was like, how is this working for you? And he said, well, I don't deal with this every day, but here's what I'm thinking. He said, the risk of this, I think, looks a lot like the risk for my patients of prostate cancer. And so there's not a lot of it. But where there's something there, it's pretty important. So he said, I use a PHQ-2. I think I'm going to add that suicide question to that. People do that in the waiting room. 90-something% of the time, there's going to be no concern there. If there's concern there, my staff will bring it to my attention. Otherwise, I don't even need to know about it. But if there's concern, they'll bring it to my attention. I think I'll make that the main focus of what I do with that patient in that visit. I'm thinking to myself, that's it. That's brilliant. So this is a big lift in primary care, but this guy's thoughts were also reasonable and functional. He said, I think I'm going to spend some time with them, see how they're doing, try to provide a little support, and I'm going to make sure they get follow-up care with a specialist, and it's going to be soon. So this was a very reasonable response to that approach, to that concern. With respect to specialty care, I'll go back to the document that Christine referenced, and that is these recommendations for standard care that you know about because you participated. Michael Schoenbaum participated in developing that. So this was, and I'd encourage other people to take a look at it. It's our best sense of what people ought to expect as standard care if they have suicide risk in multiple settings, in primary care and specialty care and behavioral health care. And generally, the basics sort of go to, for anybody with a diagnosed mental disorder or is receiving a behavioral treatment. For those two people, we think the evidence suggests now that you have to ask about this. And then if you find something, you have to kind of do what's indicated. And that's a big change in primary care and emergency department settings, but we think that's kind of what the evidence today suggests.
All right, so with that, David, you're going to wrap us up for the morning? Okay. Please join me in thanking our three panelists. Thank you very, very much, Mike, David, and Ed.
Great thought-provoking panel. Really enjoyed it. I have to take advantage to make one comment, though. I was going to ask a question, but I thought, what the heck, I'm just going to take advantage and make a comment rather than ask a question. The Golden Gate Bridge is such an interesting problem, and I think it reaches to the criticism of the zero suicide effort. I worry that, the bridge, netting the bridge isn't just about aesthetics. It's about what the net says. And what the net says is we got a serious problem in this country. And people don't want to have to be reminded of that when they look at the netting. And it is a reminder that we have a serious cultural problem, and it is on one of our most significant engineering achievements. It is such stark contrast that people can't accept it. And I think that is at the heart of the problem. And I think the same thing about the zero suicide effort. I think that part of my worry personally about zero suicide is that when you talk about diabetes and about heart disease, and those are natural consequences of health conditions and aging. They can be seen and framed within the natural process. And when we start to talk about suicide and mental health, people don't see it the same way. And it's about it's about culture and the impact of our culture, and I really am concerned about our willingness to accept those things. It's a great effort, and it is an audacious goal, and hopefully we can make some progress toward that goal. And then the last comment I had is, Mike, I have to tell you, our entire treatment was developed by simply asking patients what actually helped them. Seriously, our entire treatment was developed by doing focus groups and saying, we just finished treatment, what actually helped? And it was always the really simple stuff. And the question becomes, how do you scale it? How do you sustain it? So I've stolen 2 minutes of your lunch to make 2 comments. I apologize for that. How long is lunch? Reconvene at 1:15. Any additional thing, Bridget, you want to share about? Okay, lunch is available out.